All right, welcome everybody to the Med-Legal Greenroom podcast. I am Sam Frentzas, co-founder of the Driving Force Company, and absolutely thrilled to have Dr. Tim Deer here to talk about the spine. Welcome, Dr. Deer.
Sam, thank you so much for having me. It's certainly an honor to be here with you, and I look forward to our discussion.
Awesome. And for those viewers and members and everyone out there watching, if you don't know who Dr. Deer is, he is the founder of the Spine and Nerve Centers of Virginia's, chairman of the American Society of Pain and Neuroscience, and past president of the International Society for Pain Neuroscience. Just a few little things there to talk about accolades. So, Dr. Deer, I'm going to dive right into this thing because I like getting to the meat and potatoes. So, as far as the spine is concerned, how do we navigate the emerging areas of MIS for interventional pain and spine when considering other options of larger, more traditional spine surgeries by orthospine and neurosurgery?
No, Sam, I think that's a great question. So I think we really have been navigating it quite well. Early on in my career, I've been practicing for 32 years in West Virginia, and around the world, I've traveled and spoken to many neurosurgeons, orthospine, and we had a lot of common ground in neuromodulation. But when we started getting more into the spine, there became some friction. And one of the first things we did was a mild procedure where we decompressed the ligament. And then we had the Vertiflex procedure where we opened and did a spacer basically. And those are things that my group was brought into as the only pain group in the world initially. Things have been traditionally orthospine or neurosurgery. And what we found was because it was fluoroscopically driven, the pain people were pretty good at it. In fact, maybe more efficient at it than others. And then we got into SI fusion techniques and how we make that less invasive. Then we started doing basovertebral nerve ablation. All these things are very valuable options, but I have actually kept really good peace among my colleagues because they're options. And I think what we see sometimes on LinkedIn, we see surgeons who want to do a big fusion on everybody, and that's wrong. We see pain doctors who want to do something smaller on someone who really needs a fusion or something bigger. That's wrong. And what I find is reasonable people are starting to learn there's an algorithm of treatment, and it goes from here to here, something really simple to something really majorly invasive. But a lot of patients live in the middle. And then we have to decide, we'll try this. If this doesn't work, we're going to go to this. And we have to do it in a very evidence-based, decisive way. And what's really changed the last 10 years is we've seen no evidence develop into evidence. And so now I think we can have some guidance with guidelines and studies to tell us what to do. And I found that reasonable surgeons and reasonable interventional pain doctors have came together, and good examples at Aspen. We'll probably have 100 spine surgeons at Aspen this year. We had 0 at Aspen 5 years ago. So we're seeing that evolution where we come together, and I think that's a really good place to be, and it's good for patients.
And you talked about studies. So how do you apply that high level of evidence studies to the patient population in a normal spine practice? The motion, restored, distinct, sunburst, and accurate studies as an example.
Well, I think the worry always is, can you reproduce a study? So I helped design a study years ago for a company I won't mention who became a $3 trillion company at one point, and no one ever could reproduce that study. It was such a great looking study on paper, but in the real world, it wasn't real. And what I found was sunburst, for example. You mentioned sunburst. That's a study where we looked at a new waveform for spinal cord stimulation. And the design of the study had some flaws that hurt the study negatively, but we still met the endpoint and became FDA approval for a new waveform called burst, DR, Dirk de Ritter's invention. And that study was reproduced around the world, and it was found to be reproducible in multiple centers, sponsored, non-sponsored, independent, sham control studies. The ACRA study, which is DRG, same thing. It was FDA approval study, looked fantastic on paper, but also reproduced over 25 times around the world. The motion study is a mild study. We found that the real world data and registries look very similar to 70% of people doing well 5 years after they had the mild procedure, for example. So I do think that when they're reproducible, we can then take that evidence and say this is real world. And I think that's important. The other thing that's really, I think, valuable is when you do a study design, if you're going for a orphan population, some strange disease over here, then you don't expect that to be standard of care for everyone. But what we've done really a really good job of, and I'll give you an example. I'm doing something called the TRACK study right now, which is a bone allograft study where we pierce both sides of the sacrum and ilium. We know that that population is similar to everybody else that gets SI fusion because we have the same centers doing the study that also do lateral fusion and lateral beak fusion. So it's the same group of patients. So I think patient selection of people that you would see in your everyday practice is valuable. All the studies you just named have been reproduced, and I think that's really the key. As we go forward, we have to make sure that the studies apply to real world populations.
Okay. And then how does the role of, and I'm going to throw a $20 word out here at you, comorbidities come into play when considering the many options to treat spine pathology? What do we do when a patient has a disc, a joint, ligament, and other pathologies?
Sam, I love the question because it's an everyday question. I think everybody listening to this podcast faces this. So I'll give you an example. I'm in my office today. I have a visiting physician from Panama visiting me today, and we're talking about different minimally invasive things we could try to do. And I had a patient came in and they had degenerative disc disease, and they had modic changes on their vertebral body. So they'd be a candidate for VIVEX, which is intradiscal human nucleus pulposus. They'd be a candidate for modic changes, which would be BVN, basal vertebral nerve ablation. They also had a thick ligament. So a neurosurgeon had already tried the mild procedure on them. It didn't help them, but they decompressed the ligament. But they were a good candidate based on MRI. They're a candidate for Minuteman which is a interspinous fusion, because they actually had bony narrowing in the same region he tried the mild procedure on. They'd be a candidate for large fusion because they would also meet the same criteria. And so you say, well, what do you do first? And the way I determine that, and we all have our own methods, but they fill physical therapy and other things. What is limiting them the most? And I'll give you an example. In this particular patient, the limiting factor was when they sat, they had severe pain in their back. When they bent forward, they had severe pain in their back. When they tried to do gardening, they had severe pain in their back. So everything pointed to discogenic pain. So in that patient, we're going to try intradiscal human nucleus pulposus 5X first. They had 2 levels that met the criteria based on the studies that have been done so far. We have a level 1 study right now called Restore. They met the criteria. And then we're going to wait 3 months and see where we are. And if they're doing very well, at that point, we're done for now, because that was their worst limiting pain. Then we may have to address their facet joint. Then we may have to address other issues. But if they aren't doing as well as we hope after that period, I think about 80% of people respond to that treatment. Then we go back and do BVN because basal vertebral nerve ablation, because they did have modic changes at the end plates of L3, L4, and L5. So they would qualify for that. So I think really the key for comorbidities is we have to think about what options are available and what is the function limiting issue. Now, I'll give you an example. I saw a patient the other day that had a lot of things going on, and she really probably needed a lot of things I could do for her. But her main problem was grade 2 spondylolisthesis with leg pain. I actually texted my neurosurgeon and said she needs a fusion and sent her to see him because she really needed a fusion. Had I not looked at that flexion extension film on MRI, it looked like a grade 1. And I may have made a mistake. So I think sometimes we find people that are already at the end of that algorithm. But many times in the comorbidity population, it's very early. You try simpler things. You work your way up. And eventually you may get here, but sometimes you never get there. You stay here in the smaller activities and smaller procedures. As we both know, the smaller the procedure, the less the risk. Yes. I think that's very valuable.
That was amazing. And I appreciate that because, again, you got into details. Just trying to really up the level of questions here to you. So, and I know your time is extremely valuable. So you got that event coming up, and I'm going to put the link here below because, again, I think followers, listeners, members should attend this thing, especially if they're in this niche in the spine. Is there anything else that you would like to add? Any one last golden nugget of information that you can offer and help our providers that are listening to this?
No, so I think what you're talking about is the American Society of Pain and Neuroscience in South Beach in July 16th and 19th. And I think what that's become has become the fastest growing meeting in the world, probably. We've grown from a few hundred people 8 years ago to 4,000 or 5,000 people. And it's a mixture of surgeons and interventionalists and, researchers and people in business who are trying to develop products like, new imaging services and things of that nature. But I think the important thing to remember is we actually look at generation one of any procedure. And the first thing we do is a feasibility study, right? And so that's important. And so you're going to hear presented at that meeting, feasibility study. So a good example of that is I'm studying a new waveform for stimulation. So we're going to have 20 patients who get a new waveform that no humans ever had in a device. And they're going to be randomized to that waveform in a blinded fashion. And then there's a second waveform, a third waveform, and the current waveform that's FDA approved. And then we'll take that data, and if that's successful, you'll see things like that there. Then we're going to go to a FDA IDE for approval. And a good example of that's intradiscal implants that look almost like a breast implant that goes in the disc, and we'll be starting that study soon. And in that study, for example, it's already gone through the feasibility phase in Panama. Colleagues of ours in Panama did the feasibility phase. Now we're going to an IDE, investigational device exemption, where we get approval through the FDA. So that there's 5 FDA approved IDE studies presented at this meeting, some in the spine, some for interventional pain. And then we get that approved, and then we're going to do a large multi-center RCT to support reimbursement so patients have access. So I think one of the important things of any meeting we do, whether it be interventional pain or spine, is that we actually work to create the level of evidence that keeps building, because that is our currency. Data is our currency. The more we can produce, the better. And I do think that's important if you're a ortho spine surgeon watching this, or you're a neurosurgeon or an interventional pain doctor, you got to find the other specialists that we're talking about and you collaborate in your hometown. Because for us, it's been a great experience. And I think the patients get the best care when we talk what's best. And sometimes it's what the ortho spine or neurosurgeon offers, sometimes what I offer. But a lot of times we both have to offer something to get them where they need to be. So I think that collaborative effort is really critical. The other thing I'm going to point out here is that imaging, and I know your whole process has been on imaging, that sometimes people have imaging that's poorly done, and the radiology reading is poorly done. And I'm not hesitant to repeat the imaging. And I think a lot of times if you can't find the pain generator based on things we've talked about today, you have to go back and you have to start searching, did they miss something on imaging? Either the actual quality of the imaging, where they were moving or not moving, where they were standing, whatever it may be, but also the quality of the reading of the radiologist. I think all those things are very, very important. Of course, we all read our own films, but it's also important to have that quality imaging. So I think to me, that's what the work you're doing, Sam, with your colleagues, is really important, because many times I see patients sent to me and they say nothing's wrong with them. Their image is normal. And then I examine them, I talk to them, and I say, something's obviously wrong with this person. They were a normal person for 47 years with no chronic pain. Nothing changed. Now they have this terrible pain problem, and they're reading the MRI as normal. We're missing something here. So I do think that we have to keep searching for answers for patients we think are legitimate to find a solution. And many times that's because the imaging was really subpar. So I do think that's the work you're doing and with your colleagues is very valuable.
I appreciate that, and I'm gonna take this. Data is the currency, and at the end of the day, our neurosurgeons are pain, and then the neuroradiologists that do the reads. That's all they say, and I'm gonna take that, but I'll give you credit for it. Data, right? Data is the currency. At the end of the day, without that data, there's really nothing you can do. You can't just say it hurts here. Without the data, there's really, as a doctor, how are you going to go and treat and identify that pain generator? So everyone listening, click the link below. It's in Miami, for crying out loud. Like, you need another excuse to go down there.
Actually, South Beach Fountain Blue, so not a bad location.
Not a bad location. So please, everybody, go in there. I won't give out Dr. Deer's room number, so we won't worry about that. But you'll see him speak. I'm sure you'll see him throughout. He's very generous with his time. If you do visit, please say hi to him. If you spot him at the event, please see him speak. It's very insightful. Dr. Deer, thank you for taking time out of your day here. Go over a couple of these questions and really help our providers and listeners, getting that gold nugget of information, as I say.
Sam, thank you so much for having me. It's been a great pleasure. I look forward to talking to you in the future.
Absolutely. Thank you.